Good morning, everyone, and welcome to our weekly Independent Sage Science Briefing. We're going to start off this morning with Professor Alison Pollock, who is going to give a presentation about the most recent government figures. Okay. Professor Pollock, are you ready?
Thanks very much. I hope you can all hear me. Christina Pagel has very kindly put these slides together before going away. So I'm presenting these and I will give some introduction. So I think the really important thing to note is the number of new deaths is falling and has continuing to fall. And we have most recent data to the week ending the 17th of July. And there have been no deaths in Scotland for well over a week. Next slide, please, Kitty. And again, what we see is the pressure on the NHS has fallen away, with the number of hospital admissions falling quite dramatically. Again, Scotland and Northern Ireland doing very well, but Wales and England still having quite a few admissions at the tail end. But actually, they're still continuing to fall. And actually, what I haven't shown here is a slide which shows they are still continuing to decrease week on week. So this is very good news indeed. And I want you to hold that information on hospital admissions while we now turn to cases. And these are next slide, please, Kitty. So what we have is the number of new UK confirmed COVID-19 cases. And this is a difficult one because these people who have had a test, they are not necessarily symptomatic. They will include people who are asymptomatic. And they will also, because the criteria for testing has changed, will include people who've also been subject to mass testing. And I want to come back to this because the definition of a case is an issue. But what we can see over time is very high peak at the April, where new confirmed, and these were mainly hospital cases at that time, have been falling over time towards the end of July. But what we're now seeing with very few hospital admissions is that most of the cases that are happening at the end of July are occurring in the community. So we've got a trickle of new cases happening here and perhaps a slight increase at the end of July. And I'll come back to that at the moment. I'm hearing that people can't hear the sound very well. I'm very sorry. There's nothing I can do about it. Next slide, please. So testing can't explain all of the increase. I mean, one of the questions is that we're doing more tests and more tests being done. Pillar 1 tests are the tests that are done in hospital, but they also now include tests that have been done on healthy workers, as there is more screening being done in hospitals. So they're no longer on cases who are symptomatic and patients. And that is now the same in the community, Pillar 1 and 2. But what you can see is the huge number of tests now that are taking place every day, a dip in the July and increasing up again. Thank you. Next slide. And we'll carry on. Next slide, please. So of interest is where, if you go back to the previous slide, Kitty, thanks. What we see on the previous slide is some of the regional distribution of cases and some of the so-called hotspots happening in the southeast and the Midlands and the north. What we are seeing is variation in cases. Next slide, please. And this regional variation is being seen across countries, where we're seeing enormous variation in the number of new cases that are occurring. But the question about this is, what are the explanations for these variations, and how much of it is to do with differences in testing policies? And I think it's very important to caution when interpreting positive tests and cases, because the question we have to raise is, are these positive tests artifactual or are they real? And artifactual tests bring into question the accuracy of Pillar 2 tests, increasing numbers of positives, and I'll come back to that. And these false positives are due to changes in testing policies, where you have repeat mass testing happening weekly and monthly in nursing homes, among hospital staff, and in cities, where you're beginning to test the asymptomatic healthy people as well as the symptomatic one. The tests could be real, they could be due to changing demographics, a shift to more young people who are asymptomatic, or we're seeing more positive tests because of failures in the contact tracing. So there are lots of explanations, and that's why it's very important to hold in your head the hospital admissions, which are still going down. We're still seeing a downward trend, and you have to ask the question, are these cases actually real, or are they artifactual, or are they generated by changing testing policies? And when you get a lot of mass repeat testing of asymptomatic healthy people, you're going to generate a lot of false positives. And as the prevalence falls, the false positives will come to exceed the true positives. And this is why it's very important to integrate test results with clinical symptoms and be part of clinical oversight. So all these so-called positive cases are really just positive tests, and they need to be considered in conjunction with what's happening in GP practices, NHS 111, and hospital admissions. The tests alone won't tell you anything about the course of an epidemic, and they need to be part of a system. So it's very, very important that we proceed with caution on testing. And if you think about Leicester, there's been more testing done in Leicester than anywhere else in the country. Up to the 13th of July, there had only been 15,000 tests in that community, but there were 10,000 over the next 2 weeks. If you look at Leicester, there'd been no rise in cases, and that was in line, Pillar 1 cases, and that was in line with no rise, no 999 calls, low numbers of hospital admissions, and very low numbers of deaths. So that then raises all your questions about what the Pillar 2 test data mean. And actually, it's very useful now to go onto the government's Corona website to look at the Midlands, because you can see that even as of 28th of July, hospital admissions are still falling. So we have to proceed with caution and not overinterpret the test data. We need to distinguish between the symptomatic, we have to think about asymptomatic, and we need to really consider what the effect of mass testing is doing in terms of generating false positives. I'm going to end there. Thank you.
Okay. Thank you, Professor Pollock, for that really informative presentation. Now we're going to go to Professor Scally, who is going to talk to us about zero COVID.
Thank you very much. Thank you very much indeed. Yes, zero COVID is the policy that Independent SAGE has adopted and promoted over the last couple of weeks. And it's based on our realization that the only way that we are going to have a sustainable path forward in this pandemic in Britain and in Ireland is to get the numbers as low as we possibly can, the number of positive infectious cases. To do that requires a very substantial improvement in our finding of cases, our testing and our tracing. but it can be done. And we can see that because of the figures around the country. As you'll have seen from some of the graphs earlier, both Northern Ireland and Scotland have an extremely low number of positive cases, and they are continuing to test and try and find cases and drive that number down. And our definition of getting the outbreak under control, this is Independent SAGE suggested level, is 1 case per million people. So as you can imagine, that for Scotland would mean them getting down, for example, to 5 cases. Control be established at. And we should be then able to avoid substantial flare-ups or big incidents in communities of incidents of community spread. To get it down to 0 is another step forward. And when it can get, if it can get down to 0, as we believe it can, then we can change things quite dramatically. 0 cases effectively means the elimination of the virus from the community. And the definition of elimination is that there should be no spread domestically within the country or the territory. That, of course, raises the question about what will happen on the borders of that country and about the importation of cases. And that requires a lot of discussion and debate about what the way forward is. And there are very good examples of countries that have managed to eliminate the virus. Taiwan, a country of 24 million with a hugely internationalized transport system and economy, has had now more than 100 days with no domestic cases, but they're still getting cases detected in people who've traveled into the country, and often Taiwanese citizens returning to their home country. And the same has happened in New Zealand, where they have got down to 0 domestic cases, but they are finding approximately 12 cases per week, positives, in people who are coming into New Zealand. And again, often New Zealanders returning back home. So it is possible not only to get down to 0 and achieve that elimination, but it is also possible to maintain it. It does require a change, of course, in our attitude to international travel and the way in which we handle borders of countries or territories. There is no reason at all why normal business cannot be resumed in the country with the lifting of social restrictions once you get down to 0, as we've seen in countries like New Zealand. Nor is there any reason why business cannot continue internationally. Air freight and lorry freight have continued almost untrammeled with throughout this outbreak in and out of the islands of Britain and Ireland. And there have yet to be any reported cases from either air crew or lorry personnel moving freight as a result of that international movement. So we believe that it is a worthwhile objective because it will enable us to put the economy back into full gear. It will enable us to safely reopen schools in September, and it will enable us to remove most of the social restriction, if not all of the social restriction we have. Over the last week or so, it has been very gratifying to find that the concept of 0 COVID has been embraced by so many people, from editorials in national newspapers to the health committees of assemblies and governments. I hope that it is increasingly recognized as the way forward for Britain, and only really do it making use of our Ireland status if the 2 countries, the United Kingdom and the Republic of Ireland, cooperate. I think we're well on the way to be able to achieve that, and we can see the road that we're in at the minute, that we cannot go on like this. This will be a very, very difficult situation if it continues month after month. It would be much better for us to concentrate our efforts on getting down to 0 and maintaining 0. And that is something that the government get to try and do. And we do not accept that an acceptable level of COVID-19 is 1,000, anything under 1,000 positive cases per day, as has been promulgated by the Joint Biosecurity Centre. We believe 0 is obtainable. We believe Scotland and Northern Ireland in particular are very close, and we believe it should be adopted as the UK government. Thank you.
Okay, thank you very much, Professor Scally. So now I'm going to turn to questions from the public and the press. I'm going to start with a question that we received over Twitter. And this question is, what does the panel make of the decision to announce the latest lockdown on Twitter at 9:30 at night? And is it a coincidence that it was the night before Eid? So would Professor Mickey like to answer this one?
Hello, yes, I'm happy to do that. There have been several problems with government messaging. There's been messaging that has had very little planning or preparation, for example, when it was announced that people should go back to work or the schools should open. I think this is the least preparation that anybody's had. But having preparation is extremely important for people to have a sense of prediction and control over their situation. So having such sudden announcements is very damaging from the point of view of morale and the point of view of people's engagement and their trust in the leadership, which is really important in terms of adherence. And we've also had a real problems of mixed messaging. And what this has meant is that people are now really beginning not to understand the messaging, get alienated from it. We have something like recent polling showing that only 12% of young people understand what it is they're meant to do, and 44% of older people are meant to understand what they're meant to be doing. So the timing was, I think, really poor, but also just before so many people in these communities were going to celebrate Eid. So again, not preparation for alternatives, and there's an inconsistency when people are being told you can go to pubs, which is not an appropriate place to celebrate Eid, but you can't do this in private gardens, which is a lot safer than being indoors in a pub. So there's inconsistencies, apparent insensitivities, and this suddenness is part of a pattern of not having joined up messaging with enough preparation and planning to engage people in the response.
Okay, thank you for that, Professor Mickey. I'm going to ask Professor Kunti to come in now as well,
Thanks very much, Kitty. Just to follow on from Professor Mickey, we've had 2 additional weeks of lockdown, so we've been waiting for news for the last few days. And coming at last night at 9 o'clock, that was a disappointment. Already we have a poor morale and anxiety, anger within Leicester. But the news has come down, there's still confusion because it states that pubs and restaurants may open on Monday, but it doesn't state when we can start moving around. Whether it's today, it's obviously Eid, probably it's not right to start moving around and socializing today. But I think the clear messaging would have been very, very important. And the way the messaging is coming out is not sensitive either. So at the moment, we don't know when we are allowed to go out of Leicester. Is it today, tomorrow? Is it on Monday when the pubs open? So there is a huge amount of confusion, and it'd be good if we can get clarification as soon as possible.
Thank you very much, Professor Kunti. Would anyone else like to come in before we move on? Professor Riker, would you like to say anything about this?
I mean, the messaging, in many ways is deplorable. At the last minute on Twitter in the evening, contradicted in the morning. But at the same time, I don't think the greatest problem is the communications. I think it's the strategy, or rather the lack of a strategy, because I think what has happened is a perfect illustration of what Professor Scally was saying. This sort of yo-yo policy, where you ease restrictions prematurely, and then infections go up, and therefore you have to very quickly and in a panic reimpose restrictions, is bad at every single level. It's bad for public health, it's bad for social cohesion and for people trusting the government, and it's bad for the economy. It's a perfect illustration of precisely why we need a clear, consistent zero COVID policy of driving the infections down to a level that when we open, we can do so in confidence and people can be safe when they go back. And so when they do go out, and when they do socialize, it's not in a half-hearted way, it's going back to normality.
Thank you very much, Professor Riker. Okay, I'm going to ask Richard Mail if he would like to come now and ask his question. Richard, are you there?
I am, yeah. Can you hear me?
Yes. Hi, Richard.
Hi, yeah, thank you. So firstly, I just wanted to quickly say thank you for outlining and pushing for zero COVID, and that's for everybody. My question is looking ahead a few weeks from now. So with resurgence potentially becoming a reality, I'm also seeing growing evidence that children are just as likely to catch and transmit the virus as adults, and that the previous low incidence seen in children was likely due to the restrictions being in place and asymptomatic cases being missed. So my question is, how can I believe it'll be safe to send my daughter back to school in England in September, with a sort of supplementary of what immediate steps should government be taking to ensure that schools don't become the new care homes and seed spread into our households and the wider community? Thank you.
Thank you, Richard, for the question. Would anyone, which of the scientists would like to answer this one? So David, can you, yeah, okay, so David. You're on mute, Sir David.
What would be extraordinarily important is for the government to understand that before school opening begins in September, we have just over a month to get ourselves into that zero COVID position that Indy Sage is pressing for. Because there's no question that if we could reduce the infectivity level in the population at large to less than 1 in a million per day, we can then manage whatever happens at schools, and the risk of children then going to school is going to be much lower. So my response to this is a short period of time to manage to get the level of infectivity down to the point where we can open schools confidently. And I don't think there's one member of Independent Aid who doesn't understand the importance of children getting back to school as quickly as possible.
Thank you, Sir David. Alison, can I ask you to come in here now, please?
Well, it's really important that children are very low risk indeed. So there are, you know, no deaths in young children. And I think it's quite disgraceful that they're now going to have been deprived of education for 6 months. And we covered all this in our Independent Sage report on schools, which I would refer you to. And we all felt that much more should and could be done to get children back to education and educational experiences and the cultural and social lives that they need. And we came up with a set of recommendations that included outdoor schools, summer schools, and all of the rest of it. And I think that also needs to be located in the context of having very good community data on cases and a very effective and efficient test and trace system. The government's turning a lot of its firepower onto the public with draconian surveillance measures now, it looks like, being put in place. But it's not playing its part, which is to make sure the public health systems are effective and working. And that is really essential. And that's where the pressure point needs to come.
Thank you very much, Professor Pollock. I think, did Professor Kunti have something to add on this as well?
Yeah, there's been a couple of really good studies just within the last week. One is from the US, 50 states, showing when the schools closed, the background rate reduced hugely and there were a low number of deaths. And a study that's come out today that young children under the age of 5 as well, they seem to spread the viruses, seem to have the virus for much longer. So there is a definite risk. But as we keep saying, what we need to do is reduce that background risk and make it safe for everyone to go back to school. We all want children to go back to school. We want the schools also to prepare so that all the hygiene measures are in place, the social distancing measures in place. And as Alison said, we need data at local level, real-time data, that if there is a spike, we're not afraid to shut that school down for a period until it's again safer to get those children back to school.
Oh, Professor Riker, would you like to answer this as well?
Yeah. In a sense, this comes back to the issue of strategy, because one of the problems we're having at the moment is a series of measures, but they're not tied together in a way that they all fit together to do something. So it seems to me that we're all agreed that in many ways the most important reopening of all is schools, because the harm of schools closing is massive, and we've seen more evidence over the last week or so about the inequalities it leads to, the massive inequalities. So the first priority, if we are to reopen, should be to say, what can we do with everything else to make it safer for schools to reopen, rather than sort of ad hoc opening of pubs and ad hoc opening of gyms and so on. Everything should be oriented towards the question of how can we get our children back to school and re-establish some measure of equality in education. And the second thing is, we need a testing system, and a systematic testing system, and a testing system which is adequate at all levels, from finding people to supporting them to lockdown, and that must be tied together. So one of the things that we've been arguing is not that the government has got an alternative strategy to zero COVID. It's got no strategy at all. A series of ad hoc measures of dither and of drift and of confusion. And we need to tie together those strategies to achieve, as our first priority, and be clear about our priorities, getting children back to school safely and having a testing system which is adequate, that it can pick up immediately and early and deal with any problems that might arise. And as Professor Kunti said, a willingness, if there are problems, to act with community really immediately. So what we need is to put together all the different measures, to have a strategy which integrates them. And we don't have that at the moment, which is why we have all these contradictions.
Thank you very much, Professor Riker. I have another question which we received over Twitter. It's from Barry Stopford, and he asks, he says, I'm worried that the reason given for the northern lockdown was people congregating in households, but how would the government know? Is this another case of blaming people when it's the government that should be taking the blame? Who would like to answer this one? Professor Scally.
Well, I hope we'll have some explanation of that the answer to that very good question. I would expect that they have that information from their local contact tracing system, who have worked out that the cases are linked and that the cases come from household congregation. But I do think that they should be asked to explain the background to it. It is a very important, it's a very important question. And I go back to what some of my colleagues were saying earlier. This is no way to handle a pandemic and handle an infectious disease outbreak. To put the measures in place that have been put in place across that swathe of the population of the north of England, without explaining why, where the information came from, why it is necessary to do it at that time of night, and to announce it via social media seems to me to be absolutely the wrong thing to do and designed to undermine public confidence in the system. And we need public confidence in the system. We need to actively build public knowledge of the virus and how it's behaving and how we can deal with it. And we need to build a system that the public can have confidence in. Thank you.
Thank you very much, Professor Scally. Before we move on, is there anyone else who'd like to make a comment? Okay. I'm now going to invite Sam, who, he would like to remain anonymous, so we're just going to call him Sam. If you'd like to come forward now and ask your question, please, Sam.
Hi, thank you. Some universities have just announced that from September, they will require all lecturers who are currently working from home to return to campus to teach in person. This includes those lecturers who have been shielding. Please could you advise on what measures universities need to put in place for individuals, including higher risk individuals, to safely teach on campus? A key concern is ventilation in teaching rooms. The windows in some rooms only open a minuscule amount or not at all, and due to limited space, universities will need to use these rooms. Thank you. Sorry, I had to write my question down because it was so long.
Thank you very much, Sam. Professor Pollock and then Professor Scally. Professor Pollock, would you like to answer this first?
That's a great question. And perhaps Professor Kunti can answer it as well. I can tell you what's happening in my university, where all teaching is going online, apart from some seminar and some face-to-face contact at an individual level. And I think the universities have been, I can only speak for my university, has been incredibly cautious and careful about resuming both work in the university and making plans for next year. I think there are difficult issues for students returning and making sure there are good isolation and quarantine procedures. But I know that there's been very close working in the university with the unions, with the health and safety committees, and also with the local public health departments for contact tracing. So I feel that they've taken this, certainly in my university, they've taken it incredibly seriously, because of course parents will be asking these very same questions. I realise I haven't answered your question about high-risk groups. We will mainly, but not always, be older professors like myself, but also students with disabilities or illness. And I think that's really important. I think one of the great losses is that many universities don't have their own GP practices and health clinics anymore. They used to. And I think this is a really important omission, because I think it would be very good, especially when you've got large universities, to have health clinics on site and a lot of information packs as well. But I know that universities are going to great measures, including giving every member of staff and students, thermometers, etc. I would urge you to look at what the plans are for if you've got specific concern about your university.
Thank you.
Thank you, Professor Pollock. Professor Scally, did you have anything to add to that?
Yes, I'm very disappointed to hear that a university would take that attitude towards its staff. And I think it does require a great deal of consideration as to what the response should be. And I feel it's a bit like any workplace at the moment. And I know the Prime Minister has been very, very keen to get everyone back to their workplaces to support local economies. And it has to be a matter for the employer and the staff and their trade unions and representatives. I think it also has to be a question asked of the university: if the employee says no, what sanction the university is intending to apply to that employee. And I'd be very interested in a proper HR or an employment law response to that. But the issue that Professor Pollock touched on about the health services available, although those clinics and the student health services in particular have taken quite a hammering in cuts during the last years. And I think that's deeply unfortunate, because student health is extremely important, perhaps never more so than in this coming year. As an employer, the universities have an absolute obligation to provide an occupational health service for their staff. And staff who are concerned that their workplace might be unsafe for them should contact not just, I would say, their staff organizations, but also their occupational health service and seek advice from the occupational health service about their particular case. And I do hope that the universities as a whole across the country could come together and take some considered advice on this issue and come up with a policy rather than making it up themselves to suit their local circumstances. That seems to me to be the wrong thing to do. Thank you, Raj.
Thank you for that. Okay, we've got actually, yeah, quite a lot of people who want to answer. Can I come to Professor Kunti next, please?
Yeah, Sam, I completely agree with Gabriel. I think there needs to be a consistent policy. So this is what we're hearing, that some universities want to start in September. My university, our Vice Chancellor is in communication with the staff and students on a weekly basis, and we're just monitoring how things are going, while other universities have said, do not come back until January, or they're not going to make a decision until January. So there are a huge number of inconsistencies. But like anything opening up, just like we mentioned about school, what we need is the background risk to be much, much lower. The universities to be prepared to ensure that the risk to their staff and students are as low as we can get, and also monitoring the local progress in terms of any spikes as well. Because you could start a university and staff could start within a week with the new students coming in, you could suddenly get a spike. And that obviously will need monitoring and actioning as appropriate.
Thank you. And finally, can we have Professor Riker, please?
I think that the issue of universities is going to be massively important at two levels. I mean, first of all, and especially, I live in Scotland, and given in Scotland the rates are low, the influx of a very large number of students from across the country, internationally, many from high prevalence countries is a huge issue, and it needs to be taken very seriously. And there needs to be systematic procedures for testing, for quarantining, to support students in quarantine and to make sure that it's actually done. So I think that's going to be one of the key issues on the agenda as we go through August and into September. In terms of staff, one of the things we're currently working on in Independent Sage, and we will come back with a public consultation in a couple of weeks, is what we call a workplace Safe COVID Charter, working with the Hazards campaign. And this raises the general issue, because I think Professor Scully is quite right. This is a general issue of return to work. And the problem is that the government has, in a sense, handed over responsibility to employers. And some employers are indeed very good. And I think many of us are in universities where actually we've been remarkably impressed by the work done in our universities. But it's not going to be even across the piece. And it's very important that there are certain consistent standards that are kept to. So there does need to be a plan, and a consistent plan. And part of that plan has to be that people should only return to work if they have to, that people should be able to work from home. And in particular, if people are vulnerable, they shouldn't be required to come to the workplace. And secondly, that plan should be helped with guidance, very clear guidance by the government for a whole series of issues. And then finally, there should be certification of every workplace, including universities, by the Health and Safety Executive to say, yeah, your plan's okay and the place is safe. I think the danger of leaving it up to people and washing your hands of it is it'll be fine in lots of places, but there will be bad employers and there will be bad universities, and it will be put not only staff at risk and not only students at risk, but because of that will increase the probability of community transmission. And I think that would be appalling for the community. It would also be appalling for the place and the reputation of universities in our society. So I think it's in the interests of universities themselves to be very robust, and for there to be very robust scrutiny of plans of return to the workplace.
That's great. Thank you very much. And thank you, Sam, for the really excellent question. I'm now going to invite Stefan Simonowitz to come forward and ask his question. He's the founder of Under COVID. So yeah, Stefan, if you would like to ask your question, please.
You can't see me, is that right?
No, we can't.
Okay, I'm not sure why that is. Yeah, I would like to ask a little bit about the Joint Biosecurity Centre. I know that it's interesting that Professor Scally says that there's something these measures are designed to undermine public confidence. And that's what I've been investigating for 5 months, asking the question, why are these things happening? On the 22nd of July, just before parliamentary recess, the Prime Minister announced that Downing Street was going to take control of all COVID-19 data. And on the 8th of July, basically, he announced that SAGE and the PHE had been sidelined in favour of the Joint Biosecurity Centre. We know this isn't really led by scientists, it's led by someone from GCHQ. I'm just wondering if you have the same concerns about the Joint Biosecurity Centre. Do you know anything about it? And I have a follow-on question if you have time.
Okay, thank you, Stefan. I see Dr. Scally would like to answer that. So Professor Scally, if you could.
The reason that independent SAGE came into being was because of the absence of transparency around the scientific information, the flow of that information to the government, who that information came from and how it was being used. I think we are now in the same situation with the Joint Biosecurity Centre. In fact, I don't know, and I've asked lots of people to tell me, but they can't tell me what the centre is, what organisations the centre is joint between. The Joint Biosecurity Centre seems to me to be a shadowy organisation. Well, it is in the shadows. It's shadowed from citizens' knowledge of it. And we have no idea how exactly it operates. The papers that have been seen are very limited. They consist of some papers that have been published along with the rest of the SAGE information, and some of them were very disturbing, such as the one I quoted earlier, which suggested that an acceptable level of COVID-19 would be anything under 1,000 new cases a day. And that was promulgated without any scientific information to back it up, and we have absolutely no idea where that figure came from or how it was constructed. So I think your concerns are legitimate, and I can see absolutely no reason why the government shouldn't be as transparent as it possibly can about its response to this pandemic. That's the responsible thing to do, and that's what builds confidence. And secrecy and poor information and poor communication destroys our collective response, which should be one of collective solidarity. But it's impossible to have solidarity when there are organizations that are running the show of which we have no knowledge and no insight and no connection. Thanks for the question.
Yes, thank you, Stefan, and thank
follow
you.
up.
Yes, I think Professor Pollock would just like to come in quickly now, and then you can follow up. Oh, Professor Pollock, you're on mute.
Just very quickly, hope you can hear me. There should be primary legislation for this unit being set up, and Parliament should be scrutinising it. I completely agree with everything Professor Scally has been saying, but I think we need to go further. And if Matt Hancock is going to, this started off under Michael Cove and then it was moved under Matt Hancock. But it really does need primary legislation and proper scrutiny by Parliament. And that's what we should be calling for.
Thank you, Professor Pollock. Stefan, would you like to follow up on your question?
Yes. Through our investigations, we've found that there's a very strong link between what's happening in the UK and what's happening in America. So 6 days after the announcement that the SAGE was going to be sidelined, President Trump's administration did something very similar, ordering hospitals to bypass the CDC, which looks after pandemics, and give all the data to the HHS. And since that's happened, the data has become unstable. In the same way, in Britain, we can't get a lot of data from the government. We haven't had data about testing for more than 2 months, etc. And the data is going, in both cases, in the UK, it's going to the NHS, which is run by Palantir and faculty. And in the US, it's going to Palantir as well. Palantir is an American company. You might know about it, but it is the common denominator. It is quite a shadowy company that works with MI5, MI6, NSA, etc. So I'm just wondering if you have concerns about this data. Firstly, we don't know who it's going to, but if it's being in the hands of people like Palantir.
Thank you, Stefan. Is there anyone who would like to take this question? So David, do you have any thoughts?
No, I can't say I have any knowledge of these companies in any detail. I think the point that is being made is very interesting.
Okay, thank you, David. And thank you, Stefan, for your questions. Okay, I think now it's time to go to Ruby Lescott. Ruby, are you there? Ruby? Okay, Ruby, oh, hello.
Yeah, thank you.
Hi.
Yes, I'm quite old. My husband is also old and has heart disease. So we have been ultra careful all the time, and always wear masks. Don't object to that at all. But we have been socializing with friends like in their gardens, and shouting through a mask is quite hard work. And so I sort of made a homemade visor. And I'm wondering, is a visor sufficient protection? You know, if you're keeping the 2 meters distance, is the visor okay without a mask? And as the weather changes or it rains, if we go inside with them, would a visor be adequate protection? They're just nicer because you can see people's faces when they're talking, which is, of course, nicer.
Thank you, Ruby. Who would like to take this question? Professor Scally.
Well, I'm afraid I'm a public health physician, not an expert virologist, Ruby, but I think it's very good that you're taking that amount of, putting in that amount of effort to keep yourselves safe and keep your friends safe. And I think you should continue to take that approach. A visor has certain advantages, as you say, in being able to see the face. And for some people, it is the prime. It is important to be able to see the mouth move. People with hearing difficulties and a lot of older people have got hearing deficiencies and rely upon seeing the face in order to understand what people are saying. As I understand it, masks are preferable to visors, and that there is more of a risk of droplet spread using a visor than there is with masks. And I've heard that discussion happen about staff in shops and how safe it is with them. But honestly, if you are outside, for as long as you can be outside, and if you are keeping at least a 2 meters distance, you're really fairly safe, very safe. And unless people are singing or shouting or have explosive coughs, you probably are as safe as could be. And I think by the time the autumn comes, the only safe way for all of us is to get the COVID numbers down, and for you to know from your local public health department what the numbers are likely to be in your area and if there are any cases, because that's what we want to get to. People secure in the knowledge that there isn't any COVID circulating in their community. I'm sorry it isn't a microbiological or a microbiologist speaking to you, but that's my public health advice anyway.
Thank you.
Thank you.
Thank you, Professor Scally.
I just follow up with one little thing. I cannot see the point of wearing gloves. I know some people wear gloves. Is there any point? I mean, it's just like skin.
Yes, but the virus can be transmitted by touch, and that's why handshaking and avoiding handshaking was such a thing at the beginning. And that person-to-person touch is particularly potent in spreading the virus. the evidence seems to be that handling, for example, mail or parcels, that the virus doesn't survive long on those. And there, as I understand it, haven't been any proven cases of it being transmitted by things like mail. So touch is important, and the surfaces people touch are important. Gloves will transmit it as well. Touching cloth, that's why when you're taking a mask on and off, you probably shouldn't touch the front of the mask, and because there may be virus particles on the mask if you happen to be in the close contact with someone who has got the virus. So gloves, gloves do not provide protection, I'm afraid.
Thank you.
Far better if I could interject to say washing hands. And there's the risk if you're wearing gloves that you're then not doing what is best, which is the washing of hands.
Yeah.
Okay. Thank you, Sir David and Professor Scally. Can I ask Sarah Jones now to ask her question? Sarah, are you around?
Yes, hello, hi, thank you. I have a question on the topic of shielding. So the advice appears to be for children who have been shielding to go back to school in September, and this could be in a class bubble of, for example, 33 children in a mainstream class with no social distancing between those children. And the advice for adults who've been shielding appears to be return to work if the workplace is COVID secure and maintain strict social distancing. So I've got kind of a three-part question, bear with me, thank you. Why does it appear the advice for the clinically extremely vulnerable seems to differ on my interpretation between children and adults? What kind of precautions could help keep those children who have been shielding safe if they go back to school in these sorts of circumstances? And if it was your child, how would you be weighing up this decision about them returning to school? And I know that officially it's not a decision parents get to make. You know, we're being told that we have to send them, but, you know, that's quite difficult. Thank you.
Thank you, Sarah. Professor Pollock, do you have anything to add on this? Professor, or are there any other scientists who would like to answer this question?
I can start. I mean, the risk of severe COVID is much, much lower in children. So that's the first thing to bear in mind. But having said that, they can get the virus. They are likely to spread it as well. So those are the things that we need to take into consideration. And that's why we've said earlier, you really need the background rates to be really low before we can say it's safe to go to school, especially for those children who's shielding. In terms of the adults who's shielding, the risk is huge. We know that the age and deprivation are the two biggest risk factors for severe COVID hospitalization and death. So anyone with some of the chronic diseases, in particular cardiovascular disease, having hypertension, having diabetes, and the other conditions in the shielding list, including the immunodeficiencies and cancer, those are very high risk, and I'd be really careful about those people going back into work at this moment while the rates are still high.
Thank you, Professor Kunti. I'm going to ask Amanda Ferguson to ask her question now. If Amanda, are you here?
I am indeed. Can you hear me okay? Yeah?
Yes, yeah. Hi, Amanda.
Hello. Yes, I just want to start by saying thank you for this facility, because we're in the outrageous position in Northern Ireland where we haven't had an open public briefing in over a month because of a political disagreement, but that's another story. I wanted to start off by asking how severe, with regard to zero COVID, how severe is the risk to people in Northern Ireland from those travelling in from Britain? Would you be recommending to the Stormont government any sort of restrictions on travel, any quarantine, any other measures? And then I also wanted to ask something about shielding. We've had nearly 100,000 people shielding in Northern Ireland, and that's being paused from today. But we're in the position where, while face coverings are mandatory on public transport, they're not yet mandatory in shops. We're going through a phase of encouragement at the moment before they may become mandatory on the 20th of August. So I'm just wondering what your advice would be to those shielders who are nervous about going out. Would you recommend that they wait for the uptake to increase before they would go out, or are they okay to start moving around?
Thanks for the question, Amanda. And I'm sorry, I should have introduced you properly just then. Amanda is an independent journalist based in Belfast. So thank you for the question. Professor Scally, would you like to answer?
Well, I'll answer the first part of your question, Amanda, about travel. Maybe one of my colleagues could pick up on the shielding issue. And nice to see you joining us this morning. Yes, I think there are real concerns about the travel issue. If we are moving towards a zero COVID, it is clearly not going to be at the same pace. And Scotland and Northern Ireland and the Republic of Ireland are in a generally good position, and England and to a lesser extent Wales are not in a good position. And therefore we should not be encouraging travel, in my view, between the different parts of these islands. And I think the future for Northern Ireland is to start operating the memorandum of understanding that exists between North and South and harmonizing situation between North and South as regards travel. I still find it completely ridiculous that someone can arrive from anywhere in the world in Dublin and get on a coach in Dublin Airport to go into Northern Ireland without being subject to the quarantine arrangements or self-quarantine arrangements that are supposed to be applicable. Or indeed that something like that could happen the other way around, someone come in from Heathrow, go to Belfast, then down into Dublin and so on. So I think those arrangements are not satisfactory, and we actually really need to stop for areas that have got really low numbers, we need to put restriction in place. And I think that's going to be difficult, particularly difficult in the case of Scotland with a 96-mile border between Scotland and England. But if you look, Amanda, at the situation in Australia and what's happened in the state of Victoria with the flare-up in Melbourne and the way in which other states now have controls on state borders to ensure that the high level doesn't spill over into their states. That sort of internal border on public health grounds, I think, is the sort of thing we should be considering in Britain and Ireland. I can hand over now to one of my colleagues for to deal with the shielding.
Yes, Professor Kunti, would you like to?
Yeah, I think you do need all the bases, all the safeguarding in place if you are going to go out, if you're a shielded person. And again, the rates need to be low, but all the issues about social distancing, mask. I know that there are different opinions on masks, but the data, the best quality data show that you can reduce the amount you exhale in terms of the virus by 90% by wearing masks. And we know data from Germany shows that after mask wearing, there was reduction about 40% in terms of transmission. Also, 20% of the transmissions occur outside. It's not zero. So you want to reduce the risk outside as well. 80% of the risk is mainly indoors, and you're more likely to spread within indoors, about 20 times more likely to spread indoors. But if you're outside, there is still this risk. And so you do need to take all those precautions.
Okay, thank you very much, Professor Kunti. We're rapidly running out of time. So yeah, we just should try and get through a few more. We've actually got a question for Professor Carl Friston. It's a question we got over Twitter, and it says, I looked at Carl Friston's charts and can see very clearly that the NW is a hotspot. Are there any other regional hotspots developing? Professor Friston, would you like to answer that?
Sure. So Professor Pollock showed us the regional dashboards in her presentation. So there is a facility, there is a dashboard that you can go to look at the estimates of the underlying rates of new cases per day, the prevalence of infection, and other ways of characterizing or quantifying how far any particular region is through the epidemic. The graphics which were shown earlier in the presentation show how the regional hotspots are flickering over a timescale of a few weeks. So Leicester is doing particularly well now, suggesting that the local containment has been quite effective in bringing down the estimated rates of new cases and prevalence of infection. As that is happening, there are other little flickers. So you can imagine sort of a picture where there's a forest fire with little flare-ups here and there. What is not apparent from the graphics that we saw earlier is that they've been normalized to the maximum. So that generally, the overall, the degree of burden and flare-ups are declining, but there will be regional hotspots, and you can go and look at your own area and compare it with other areas. Just in closing, the numbers that you see there are very much dependent on some of the issues that Alison was talking about before in terms of how you interpret different kinds of testing results, pillar 1 versus pillar 2. So these are estimates that speak to the quality and the nature and the disaggregation of the data. So I'm just making that point because a number of the questions we've had about where is the data coming from, how much access do we have to it, how do we interpret it, and what we'd need to know to make a full interpretation. These are very, very pertinent issues, which I'm sure we're going to be revisiting as we try and understand these local secondary waves and the way that the difficulties that we're going to have in terms of implementing zero COVID, and in particular the time sensitivity of that. So all the analyses that you will see, or a large number of the analyses that you'll see, the estimates you'll see on that dashboard, speak to the fact that now is the time, if we are going to have an efficient testing, tracing, isolation support system that's going to make a difference. It's not going to get any better. So now is the time to act.
Thank you, Professor Friston. We have another question from Twitter, which I'd like to read out. And it is, I live in Wigan and I'm very confused by last night's announcement. I'm not allowed to visit my mother in her garden, but it's still okay to go to the pub. Does the committee think there's a sound scientific basis for this advice, or is the government pandering to the pub trade? Professor Scally, what are your thoughts?
Well, I do think, and I have thought for a long time as a public health physician, that the alcohol industry has an enormous influence on this government and previous governments. And that's not an influence for the good. It was very noticeable, I think, when the Chancellor brought forward his first budget at the early days of the pandemic, that one of the things he included in it was some relief for the alcohol industry. And I do worry that we have put the opening of pubs, as indeed one of my colleagues said, opening of pubs, gyms and nail bars. And we apparently given them more attention and more effort and probably more resources than has been devoted in terms of policy formulation about helping our schools get open in time to educate our children. And I think that's deeply regrettable. And I do think there is an industry influence here. But it's also clearly a behavioral issue as well, because the consumption of alcohol in company leads to a reduction in inhibitions, and this virus thrives on reduced inhibitions. And therefore, in my view, the last thing that we should be lifting restrictions on are places where alcohol is served. And that's very much my personal position as a public health physician, but I believe it to be the right position. Thank you.
Thank you. Professor Riker, would you like to add to that?
Yeah, so let me come at this as a psychologist, a behavioral scientist, because in many ways the issue isn't what we think, it's what you think, it's what the public thinks. Because compliance with measures is critically dependent upon seeing them as legitimate and equitable. And I think the reason why there was such high compliance with the original restrictions, with the original lockdown, was because people saw their necessity and they saw their consistency. There were issues, but nonetheless, people held out. The problem we're having at the moment is, number one, there's a sense of inconsistency, as was pointed out in the question, and there is a sense of illegitimacy, that this is favouring some groups over others, that certain interests have louder voices than others. And to the extent that happens, then it's catastrophic for compliance and catastrophic for maintaining the behaviours which will restrict the spread of the pandemic.
Thank you very much, Professor Riker. I'm really sorry to say, but we actually need to wrap up. We're out of time. But thank you very much to all the members of the public who put forward some questions, and we're inviting them every week. So if you didn't get yours answered this week, then please come back next week. And thank you to the panel for your very informative answers. And yes, we will see you this time next week. Thank you.